These are the indications for temporary pacing. These are the contraindications. Obtain central venous access using standard technique. Use a 6 French sheath and a right IJ approach is preferred. Here's an example of a transvenous pacing kit. Before performing this procedure, familiarize yourself with the kit. Make sure you have the correct kit. You may accidentally grab a pacing swan kit. A balloon tip catheter is preferred over a pacing swan as it is more stable. Here's an example of 3 different pacing catheters. The white is a balloon tipped. The blue is a screw tip, and it should always be placed with an attending supervision. The yellow is a pacing swan.
Prepare the pacing wire. The pacing wire should be uncoiled onto the patient. The unique features of this wire are a protective shield, which not only protects the distal tip of the pacing wire, but maintains the curvature to successfully float the pacing wire. It is important when uncoiling the pacing wire to maintain its original curvature, which is designed to facilitate entry into the right atrium. Next, the contamination shield is placed. The contamination shield needs to be placed over the pacing wire prior to floating it into the patient. The contamination shield can be placed out of the operator's way until the pacer is successfully placed. The contamination shield should be left compressed until capture is achieved. Next, the balloon is tested at the distal tip of the catheter to ensure that it inflates properly. This usually requires approximately 1.5 cc's of air. Once proper functioning of the balloon is verified, the balloon should then be deflated. At this point, the pacing wire should be inserted into the patient. Again, follow the curvature of the wire. Advance the catheter to a length of 20 centimeters and inflate the balloon. It is important to insert the catheter wire to at least the 20 centimeter mark prior to inflation to ensure that the distal end of the wire and its balloon has passed through the entire length of the Cordis catheter. The valve must be turned to the locked position to maintain balloon inflation. The balloon allows the wire to float gently into place and reduce the likelihood of intimal damage. Once the balloon is inflated, the sterile operator should open the package with the adapters that connect to the distal end of the pacing wire. Once the adapters are inserted, the distal end of the catheter can be handed off to a non-sterile operator. Ports should be inserted positive to positive and negative to negative. At this time, the pacing box can be turned on. The rate should be at least as high or higher than the patient's innate rate. As the catheter is advanced, watch the monitor for pacer spikes. The output should be started at a high level, and once capture is sustained, dial back to a level in which one loses capture. Then, dial back up to a minimum output to sustain capture. Once this capture is sustained on the monitor, the contamination shield can be connected to the Cordis port and the Cordis secured. It is important to remember that at any time an air embolism can be introduced through an unsecure catheter. All precautions should be taken to prevent this occurrence. The sheath should connect securely to the Cordis catheter. Once the sheath is secured to the Cordis catheter, the entire line should be secured using 3/0 silk on a straight needle. As always, a sterile barrier is applied to reduce the incidence of infection.
These are the complications with placing a temporary pacemaker.